Hi, everyone. I want to start by thanking the organizers. It's really great to be back here, and I just wanted to comment on two things that have changed a lot since the last in-person Newton meeting that I attended. The first is I think we have a much more diverse group, and I'm really thankful for that. I think we have a long way to go as a community and as a field, but there's definitely been progress, and I think that's important to acknowledge. And then the second comment I wanted to make is on the breadth of the program. I think it's just really exciting that we can all be in a room together and talk about everything from formal inference methods to policy interactions to what I'm going to talk about, which is more sort of the institutional and organizational level of things. And I'm just having a really good time, and I hope everyone else is too. Okay, so with that, I'm going to move on. So I'm talking about modeling at the policy interface, moving forward with lessons learned. So I do think it's important to have a little bit of context for this presentation. I'm presenting as a CDC official, but as Valerie mentioned, I'm very new to the CDC. So I started at CDC in November of 2023, and I spent the 7 years prior to that in South Africa. So I'm framing this talk in terms of lessons learned, but those are lessons that I'm carrying with me from South Africa into a new context. And so they're going to be very general lessons that I hope apply across contexts. I'm not going to talk about how I learned those lessons, but I'd love to talk about that over coffee in a different forum. I'm going to be talking about sort of how we're moving these lessons forward within the CDC. So first, starting off with the lessons, there are 4 of them. We were told that we shouldn't have 6 bullet points in a 15-minute presentation, so I'm going to try to squeeze in 4. So the first is that situational awareness is the foundation for decision making. From my view, this requires routine analysis with repeatable workflows, and a lot of what we're doing to promote this situational awareness is putting those types of pipelines in place. The second lesson is that decisions are made through formal response structures. So everything runs on having the right relationships and integrating at appropriate levels in the response structure. This is how you know what questions are being asked, and it sets you up to be able to provide the right information to the right people at the right time. The third lesson is that different audiences have different needs, and it's necessary to tailor communication accordingly. And the final lesson is that you can't build capacity during a crisis. You really have to run with what you already have. So moving forward, I'm first just going to talk a little bit about the Center for Forecasting and Outbreak Analytics, which is the newest center within the Centers for Disease Control and Prevention, which is the main sort of national public health agency within the US. So CFA's mission is to harness cutting-edge analytics to improve response to public health emergencies, and we're sort of doing this in a fairly structured way. So the center is divided into 3 different divisions, which are aligned with 3 of our primary goals. So these are summarized as predict, inform, and innovate. So the predict division focuses on delivering actionable analysis and response-ready modeling tools. The inform division generates practical decision support communications products, and the innovate division, or the technology and innovation division, is focused on driving technological and analytic innovation. And then the director's office focuses on building world-class forecasting and outbreak analytics organization. And so you can sort of see how our structure is really tailored to try to address this mission. Within the predict division, which is where I sit, we have 2 branches, the real-time monitoring branch and the analytics response branch. Each of these branches has 3 teams. I'm not going to go into detail at the moment about this, but again, I'm putting it up there so that if people have questions or are interested in more information, I'm happy to talk about it at a future time. Okay, so situational awareness is the foundation for decision making. So we're trying to move forward with this lesson, again, sort of in the way that we're structuring everything that we do. So the real-time monitoring branch produces routine products on a regular cadence to support CDC responses and public health activities. I'm the chief of the real-time monitoring branch, so sort of all of the activities that occur within the branch are things that I'm helping to orchestrate, trying to protect the analysts to be able to do the technical work, and helping set priorities, et cetera. So the real-time monitoring branch has 3 teams. The nowcasting and natural history team tries to understand current disease burden on national, state, and local levels. The short-term forecasting team looks a little bit into the future, focusing on disease burden over the next few weeks. And then the scenario modeling team is focused on sort of what-if questions and longer time horizons, but still within a framework that allows them to produce routine analyses and update situational awareness on a routine basis. So I'm just going to quickly give a couple of highlighted projects. These are all things that are available that you can dig into more deeply. But just examples of the types of things we've been doing is producing reproduction number estimates for flu and COVID. So we do this on a weekly cadence. This is available publicly. It's incorporated into routine sort of state level public health updates. The short-term forecasting team has been working on methods to integrate wastewater data into hospital admissions forecasts for starting with COVID-19. We're now hoping that this season we'll be able to launch it for flu as well as those data streams come online. The link here is to a public code repository. We don't yet have a publication or a more formal description of the methods, but the code is available, and there is some documentation there. And then the next thing I wanted to highlight is the scenario modeling team has been contributing to what we call our respiratory virus seasonal outlook. So this is sort of a high-level document that is released and then updated throughout the respiratory virus season that sort of tries to give, in very broad strokes, what we expect the season to look like in terms of things like the timing of the peak burden of combined respiratory virus diseases, the height of that peak, and the sort of averted burden that would be expected with different levels of vaccination. So we anticipate that the 2024-2025 respiratory outlook will be available by the end of this month. Okay, so moving on to lesson 2, which is that decisions are made through formal response structures. I feel like there should sort of be an asterisk here. I think decisions are made by a very small number of individuals, and response structures are a way for evidence to flow, but ultimately the people who are in the room making the decisions may or may not actually have received that information. But the best way to ensure, unless you have the ear of someone, a very senior executive, the best way to ensure that the evidence flows into the decision-making process is through these formal response structures. So US public health responses follow general principles that are laid out for incident command systems. In the US, there are 2 main documents that sort of govern how we do this. The National Incident Management System, a document that's put out by FEMA, the Federal Emergency Management Agency, and the National Response Framework, which is put out by the Department of Homeland Security. Within CDC, we have something called the All Hazards Plan, which outlines a general incident management structure, which then is adapted to the needs of specific responses. And so this is a very generalized, simplified version of what those types of structures look like, where we have the CDC director sort of at the top outside the IMS structure, but everything flows through the incident manager to the CDC director. And then there's various different types of of scientific and non-scientific staff, and that are doing different things, and most of the evidence generation is occurring within what's called the scientific response section, which typically reports to the chief science officer, who reports to the incident manager. The actual realization of this is much more complicated. Again, this is a very simplified version of an example response that I was recently involved in. So the structure here is a little more complicated. We have two main task forces. Each of those task forces has a number of different teams. The Domestic Readiness Task Force, which is where the modeling team fell, had 8 different teams, as well as a number of senior advisors. And then you can see that that there's all this other stuff that's going on as well with the chief data officer, the chief health equity officer, communications policy, and all of this sort of has to come together in a way that efficiently provides the information that's needed, as well as supports the actual response activities. This is a little bit more of a modeling team view of that same response. I was one of the modeling team co-leads, and we directly interacted with all of the entities that are on this slide. I know there's a lot of acronyms here, so this includes the center directors and the immediate office of the director, so not Mandy Cohen herself, but her direct advisors, the incident manager, the task force lead, and then various other groups, some of which were actually part of the formal response and some of which were not. So the communications, the state territorial, local, and tribal engagement team, the pox and rabies branch epidemiology team, the data analytics and visualization team, and the lab and testing team. At various points in the response, we had to engage with these different partners in order to either get the information that we needed in order to inform the modeling, or to ensure that the modeling was being communicated to the right people and in the right way. Lesson 3, different audiences have different needs. So just wanted to highlight that the presentation of a single analysis can take many different forms depending on the audience. So I'm showing one figure here, which is the public-facing view of this analysis, but in terms of what actually goes on behind the scenes, we have everything from a one-page document that attempts to summarize all of the main findings, as well as the approach that was used and the caveats and limitations. We had a sort of a presentation that we gave to the White House, which consisted of 4 slides, which was essentially 10 bullets and 1 figure. We did a deep dive with the poxvirus and rabies branch epidemiology team, which was 14 slides, all focused on what the upper bound of our sensitivity analysis for the household secondary attack rate should be. So there's a wide range of ways that you need to be communicating about and anything that you're doing, but this depends very much on who it is that you're talking to. For the sake of time, I'm going to move on. So lesson 4, you can't build a capacity during a crisis. So in a sense, this is really where the CFA comes from. So there was a recognition following the pandemic, or part of the way through the pandemic, that there was a lot that we needed from modelers, but we didn't have a way to, we didn't have an institutional way to make the modeling work that was going on flow into the response structure in a way that it was as useful as it should have been. And so CFA is sort of a nucleating entity, and the idea is that we should in the future have standing capacity both inside the government and outside the government to do this work, and ways for it to flow, the evidence to flow. So in terms of internal capabilities, we're sort of focusing on these 5 areas. So the communication and data visualization, a lot of that is done by the Inform division. Sort of everything, especially more on the right-hand side here, is housed within Predict, the epidemiology and public health, and the mathematics and statistics, and to some extent the software engineering. But then we also have the technology and innovation division, which is really, in the longer term, going to be set up to really support that software engineering aspect of things. So this is sort of the internal capabilities that we're building, and then we also are supporting academic partners through InsightNet, and InsightNet derives practical innovation for state and local partners. So what does that mean? So on the one hand, it means that they are going to be sort of standing capacity that's available to support state and local health departments as the need arises. But on the other hand, they're also doing a lot of innovation, and they're developing new capabilities, which we hope to be able to also harness at the federal level. So I think I just wanted to close on this note. So there's a lot that we can learn from other contexts. We want to be part of this global conversation on how we move forward as a community. That is certainly why I'm here. I think that's also why CFA has sent 5 of our analysts here. So if you haven't met them yet, I just want to call out Eric Mooring from our and Chris Vallot from our Community Mitigation and Economic Impacts team, Emily Pollock and Paige Miller from the Key Populations and Setting team, and Damon Bear, who's on our short-term forecasting team. So if you haven't talked to them yet, please do. They're really great, and they're excited to be here. So I want to make sure that they get the most out of this experience. And that's it. Thanks.
We have time for a few questions. Anybody?
Great talk. How has it changed the data conversation, the existence of this team? Does it mean that people see the value of more involvement to a level of willing to share data?
Yeah, it's a complicated question. So the question, as I understand it, is how has this changed the data conversation? And I think that there's many data conversations, of course. I think that one of the things that we're trying to do within the center is show the value of the data, but also in a way that we're hoping in the longer term might motivate there being more data available, not just to us, but to the academic partners, but also publicly. I think that's going to be a very long process. I think that we're at the beginning stages of that. We've started having some conversations with different data generation programs about that topic. But my view at the moment is that it's going to be a very slow process. Within CDC, a lot of what I do is talk to people about data and data access and trying to get make those connections and build those relationships. But I think we're having much more success internally, but it is definitely one of the things that we're trying to do is sort of promote the public accessibility of those data.
Any more? Yeah, you go ahead, maybe if you remember.
Yeah, so thank you for the great talk. I think it was very informative. So I was wondering, before Center was created, or when the pandemic struck, what was the situation, more or less? I mean, like, what was the
That's a great question that I don't feel like I'm the best person to answer because I was in South Africa during the pandemic and I didn't have a lot of awareness of what was going on in the US. I don't know if someone else, like maybe Justin, would want to comment on the question of what the experience from the academic side was during the pandemic.
Yeah, I mean, it was very ad hoc. It was very much people, making calls, I think there was also a tendency, so from the academic side, so from the state, like I state, states and locals were basically like pairing with the academic partners who they had phone numbers for and were willing to work with them, you know, so like we were in touch with California, you know, some localities like Austin, Texas probably had one of the best, you know, informed responses of any place because Lauren Ansel Myers happened to be there and like worked directly with their government. At the federal level, you know, I think the interface like flowed. It was flowing both through the CDC at times, but also it was flowing through like the emergency, you know, the FEMA emergency response and command center structure, and like they went to contractors who they, you know, to look for through military stuff and things like that, who then went out and just called the academic partners they knew. So it was all like, I think ad hoc is the best summary of it, and I think also there was, because of that, there was I think that was probably evident from everywhere, there's sort of a little bit of a pick and choose nature to how things were consumed up the chain, because there was no established, structured set of models and advisors, you know, and government agency, actual government centers there to provide this information.
Okay, thank you. And I'm sure there's more to talk about at coffee, but for now we'll just thank Juliet.